Today, the topic of discussion is Introduction to First Trimester Point-of-Care Ultrasound. First trimester ultrasound is a vast topic, but we're going to address it based upon the guidelines provided by the ACEP and AAFP. Here is the list of topics that we'll be covering today. We'll go over this in detail in the next couple of slides, and towards the end we'll also have a Q&A session, so you'll be able to submit questions and I'll be happy to answer. Here is a brief summary of the ACEP guidelines for performing first trimester point-of-care ultrasound. And if you look at these guidelines, you notice that they want you to be familiar with transabdominal and transvaginal ultrasound, be able to obtain the adequate views, and to determine fetal heart rate, gestational age, be able to identify the female pelvic anatomy, and to be aware of findings that are expected in the intrauterine pregnancy as well as ectopic pregnancy, and be able to recognize embryonic structures like gestational sac, yolk sac, and fetal pole, and in the event of embryonic demise, you should be able to diagnose that as well, in addition to a molar pregnancy and ectopic pregnancy findings such as pseudogestation sac and free fluid, or as presenting as adnexal mass, or even adnexal masses that could be present when the patient is pregnant. The AAFP guidelines, as you can see, are kind of pretty similar, just slight variation. They both talk about transabdominal, transvaginal scanning techniques, the presence of intrauterine pregnancy, and also viability of the pregnancy. One thing that is important and has been made more aware of, that for the heart rate determination, you would like to use the M mode rather than the color Doppler or spectral Doppler, because these are emitting a higher dose of the ultrasound energy. And if you remember that the organogenesis is happening during the first trimester, and even though there is no documented evidence of injury to the embryo or the fetus in the first trimester with the ultrasound and the diagnostic ultrasound levels, but it is best to still follow the LARA principle to be able to create a much more safer environment for the developing embryo. Of course, we're going to be looking at gestation age estimation using the crown rump length, and be able to recognize free fluid in the pelvis, and also free fluid around or anterior to the uterus as well. And lastly, we're going to talk about molar pregnancy. And of course, the molar pregnancy, as you know, has a typical snowstorm appearance or a cluster grape appearance on the ultrasound. Here are some of the common indications for performing first trimester ultrasound in a patient who's pregnant. One would be pelvic pain or vaginal bleeding, just to confirm an intrauterine pregnancy, to confirm whether it's a viable pregnancy, that means cardiac activity is present or not, to look for ectopic pregnancy if that is suspected, or to look for twins or triplets, or the number of embryo present, as well as molar pregnancy. On this slide, we see diagram representation for both the transabdominal as well as the transvaginal approach. We can see the probe placed on the anterior abdominal wall on the pelvic region, and we are looking through the bladder. This one, the bladder is not very well distended, but you kind of get the idea that we'll be looking. So if the bladder is full, it would be all the way up here, and we're looking through the bladder into the uterus and the adnexal structures. The probe marker for performing a mid-longitudinal view will be pointing towards the patient's head when you do a longitudinal view, and when you're performing a transfer scan, the probe marker should point to the patient's right side when you're doing a transfer scan. When you look at the transvaginal approach, the probe indicator is pointing towards the ceiling. When you're doing a longitudinal or the sagittal view. When you are performing the coronal view, we will have the probe marker pointing towards the patient's right side. That would be required by performing a mid-longitudinal or sagittal view, and then simply turn the probe 90 degrees counterclockwise to obtain the coronal view. Here we see two views that have been obtained. On the left side, we have the mid-longitudinal view from the pelvic region, and of course we have the cervix over here, and this is the fundus, and this is the body of the uterus. In the middle, we have this white line that is representing the endometrial stripe. In the cervical region, this is the cervical canal, which is closed at this time, and also you can see the vaginal stripe. Anteriorly, we have the bladder, and another important structure that we see here is this is the cul-de-sac over here, and you can see some fluid present. Because this is a dependent portion, so there will be fluid collection. Keep in mind that fluid could be physiological. In this particular case, the patient scan was performed around the time of ovulation, so a little bit of blood or fluid could be seen in this region, and that is physiological fluid. On the other side, on the right-hand side, we see the bladder. This is the bladder right here, and we have the uterus posteriorly, and you can identify the endometrial stripe, and of course surrounding that we have the myometrium. So the left side of this side is going to be, this is the right hand side, and this is going to be the left hand side of the patient, and of course this is anterior, and this is posterior right here. So if you're looking for free fluid, we'll be looking in the posterior region also, and sometimes would be seen a little bit on the sides as well. Here we have the two transvaginal ultrasound views, and of course when you're scanning the transvaginal approach, you have the patient in lithotomy position. Bladder should be empty. Definitely want to have the probe cover on, or a condom, and before you install the probe cover, you want to definitely put some ultrasound coupling gel as well on the transducer footprint where the ultrasound beam is being emitted from and captured. And so, and you can put some amount of sterile gel if needed on the probe sheath on the outside if needed. After the procedure, you definitely want to perform a high-level probe disinfection procedure to make sure there is no cross-infection from patient to patient. Even though the probe sheath looked intact, we still definitely want to do that, and also contact the ultrasound manufacturer provide the transducer so they can provide you the correct or the recommended technique and chemicals and methods for performing that level of disinfection. Here on the top, we see the mid-longitudinal on the saddle view. You can see so much detail of the endometrial stripe. You can even appreciate the 3 layers. This is a trilaminar pattern. and you can see the myometrium as well as the cervix as well. In the lower image, we again can appreciate the endometrium pretty well, and it seems like this particular patient has an inverted antiflex uterus, so the view is almost looking like the transverse view, but the plane is coronal, so the plane of cut is the coronal plane, and the view, because the uterus is pointing anteriorly, so we have more like a transverse view over here. The first sign of intrauterine pregnancy is the intradecidual sac sign. We can see over here that a very tiny anechoic structure is seen within the endometrial cavity here. It is eccentric in location and may have a very faint echogenic rim, and the size is about 2 millimeter, and this is seen about 4.5 weeks of gestation, and it's not seen always. It's about 60% of intrauterine pregnancy you will be able to see this sign. Discriminated level is 47 days, but also be aware that it could very well be also fluid collection. Could just be a fluid collection in there, or it could be the pitfalls. It could be a decidual cyst. At about 5 weeks gestation, and typically, if you look at all these images that I'll be sharing with you today, most of them have been obtained using the transvaginal approach. So at around 5 weeks, you'll start seeing the gestational sac. As you can see, that's the gestational sac right there. That's a small anechoic structure, and you also see that it's clearly eccentric in location. The white line is representing the endometrial stripe, so it is towards one side. As you can see, it's more posterior here. So positive pregnancy test with the anechoic area in the endometrial cavity may be an intrauterine pregnancy. We notice here is a chart showing the gestational sac diameter along this y-axis, and gestational age in weeks along the x-axis, and it kind of increases as the gestational age proceeds further into the pregnancy. On the transvaginal ultrasound, we will be able to see around 5 weeks. After 5 weeks, you'll start seeing double decidual sac sign. In this example, of course, you can also see the yolk sac here, and that is definitely more than 5.5 weeks. So around this time, you should be able to see two distinct echogenic rings. This is the inner one, and this is the outer ring, and you can see more posteriorly, very much more clearly. So this is known as the double decidual sac sign, and the outer is representing decidua, and the inner is representing the chorion. At this point in the pregnancy, you have to be able to recognize the pseudo-gestational sac, which actually is suggestive of ectopic pregnancy. Keep in mind that it's not seen in all cases of ectopic pregnancy. It's about 10 to 20% of cases. It's just a single one echogenic rim, and has a teardrop shaped and also has acute angles. What exactly is happening is blood and fluid from the fallopian tube that is collecting in the endometrial cavity. Again, keep in mind it is a pregnancy. It's just that it's ectopic, so the pregnancy test will be positive. HCG levels may be low, and clearly that is the fluid in here. So all the fluid, but there is no double decidual sac sign. Here in the top image you can see, and also there's no yolk sac or embryo inside here. Then above image you can see the double decidual sac sign, and also a yolk sac present inside the gestational sac. As mentioned earlier, on the transvaginal scan, we should be able to see the yolk sac at about 5.5 weeks gestation. It's about 3 to 5 millimeter in diameter. Size is important because if it is too large, for instance, if it is enlarged and the size is more than or equal to 7 millimeter, it's going to be a bad outcome. Could end up with failed pregnancy. Also, if it is calcified yolk sac, that also suggests a bad outcome. Keep in mind that the mean sac diameter is about 8 millimeter when this appears, and also it disappears naturally around 14 to 16 weeks, and it decreases in size gradually. So it should not be increasing in size too much, and definitely not going up to 7 millimeter or more. And also keep in mind that the yolk sac is number of yolk sacs is equal to number of amnions. That is important when you are determining amnionicity in twins or multiple pregnancy. So this over here is the yolk sac. At 6 to 6.5 weeks gestation, we will have an interesting sign called as the diamond ring sign. Interestingly enough, the embryo and yolk sac sitting on it, it looks like a diamond ring, like the diamond ring that we are familiar with. And this is a good confirmation sign for presence of the embryo development. And this also confirms intrauterine pregnancy if it is present within the endometrial cavity. And approximate mean sac diameter, which we'll address in a moment, is about 16 millimeter. Keep in mind that if the mean sac diameter is more than 24 and you do not see the embryo, that is highly suspicious of a bad outcome. On ultrasound, the amnion is visible first at around 7 weeks gestation. Subsequently, it expands and the yolk sac becomes free, floating, and it fuses with the chorion at about 14 to 16 weeks gestation. And the developing embryo is located inside the amniotic cavity. So here is the embryo. See the embryo head and the trunk. And of course, you can see now that the yolk sac is separated. And also you can see the amnion, the thin echogenic line kind of going all around the embryo. And that is the amnion. And the empty amnion sign is suspicious for pregnancy failure. So definitely do a follow-up ultrasound if you do not see an embryo within the amniotic cavity. So let us now review the embryo morphological development process. As seen on ultrasound, we can see at around 6 weeks gestation, it appears like just a really tiny dot, and that's the diamond ring sign. At about 7 weeks gestation, it starts looking more like a grain of rice. Here it is. At about 8 weeks, it represents or looks almost like the kidney. It's a kidney-shaped structure, and there it is. And subsequently, it grows in this fashion and maintains that shape. The size increases. And at about 10 weeks gestation, we do not call the embryo anymore. We actually have a new name for it. We call it the fetus. So make sure you use the right terminology. After 10 weeks gestation, we do not call it an embryo anymore. It's going to be a fetus. The cardiac activity, the cardiac pulsations are first seen around 6 weeks, sometime earlier if you use a very high resolution transducer. You may be able to see it 5 weeks, and the embryo size about 1 to 2 millimeter, and should be visible when the crown rump length is about or equal to or more than 7 millimeter. Best seen with the transvaginal because of the high frequency and high resolution, and of course the cardiac activity can also be seen with transabdominal in some patients, and definitely down around 7 weeks you should be comfortable be able to see, make sure the bladder is full. And I'm going to see if I can play the video. There you go. You have the video playing now. Very faintly you can see the cardiac activity happening over there. It's a slight flicker, and that is actually the cardiac activity in the embryo. Do not use color Doppler or power Doppler because those have high power levels, acoustic levels, and those are not recommended because they are not going to give us additional information. We are simply going to be inseminating the embryo, which is very tiny, and organogenesis is occurring with high levels of ultrasound power, which could possibly disrupt something or harm the embryo. But keep in mind that as of now, there is no documented evidence of that, but we still want to make sure that we use the Lara principle when performing first trimester ultrasound. We tend to use the M mode while scanning the embryo to determine the fetal heart rate, FHR. And there are calculation packages available on the ultrasound device, which all you have to do is get an M mode tracing through the cardiac activity region, run the cursor right through. I'm just going to try to draw something here. So here is the imagine this is the embryo. There's cardiac activity occurring here. So we run the MO tracer right through that and excuse the wavy line. And here we can see a tracing being, it's not very clear. So I'm going to draw something here. For instance, over here. So if you have it says in a certain structure of the heart, and it's going to be going like this, up and down, you know. So there are different ways of doing this, and it all depends upon the device manufacturer. In this example, it's actually, you can put it right at the either peak or the valley. So in this one, you're actually doing like this, and you put one cursor right here, and the second cursor is right to the next one. But there are some devices that take two in consideration. So for this one, when you close this cursor, it would determine the fetal heart rate automatically. For the other devices that I've seen, they use two of these. So you take, this is the first peak right here, so coming down. So that completes one cycle, and then it's the second one. So when you put your cursor here at this peak, then or the valley, you will be able to determine the fetal heart rate. The system automatically calculates that and displays it on the monitor. Here's an interesting chart. It's going to show you the variability of the male fetus versus the female embryo of the fetus. You can see that there is a slight variation, but you cannot determine gender based upon the fetal heart rate. One of the measurements that we perform to determine gestation age during the first trimester is known as the mean sac diameter. As the term stands for MSD, it would mean mean. That means you have to take 3 measurements and add them together and divide by 3. So that would give us the mean. The system automatically calculates and displays after you measure them. So you can see in this view, we have that a transverse view through the showing the gestation sac, and we just measure side to side, put the caliper at the junction of the anechoic area with the hyperechoic area. And on the next image, you get a mid-longitudinal view, And just once you get the view, just measure the 2 dimensions here and you put them here, plug it in, and divide by 3. If you want to do that manually, that would give us the mean sac diameter. Interestingly enough, if you get the mean sac diameter, you can add 30 to that as a constant, and that would give us the gestational age in days. In this particular example, the mean sac diameter was 24. So the gestational age is equal to 24 plus 30, which is a constant, and that's 54 days. Keep in mind that the MSD is from 16 to 24 with no embryo seen within it, and when you scan through and through cephala to choroid and also side to side, and that would be suspicious for a bad outcome. The crown rump length, or the CRL, is a very, very important measurement that you will be obtaining during the first trimester. It is the most accurate measurement of gestation age. Is useful around 6 to 13 weeks gestation. Image should be magnified to fill the entire image width, so don't have a tiny image in there, just make sure it's filling the entire screen. And the reason for that is if you make a tiny error in the caliper placement, the error would be almost insignificant. So make sure that you do that correctly. And the measurement length is this one here. It should be ideally perpendicular to the ultrasound beam. So the ultrasound beam is coming from the top, and so we definitely from anteriorly, and so we want this plane to be perpendicular as much as possible. Definitely if the embryo is sitting vertically, then you don't want to do the measurement. You want to wait until you get the right position of the fetus or the embryo. It should be obtained in the mid-sagittal plane, and make sure you don't include the limbs or the yolk sac or the cord. The embryo, the fetus, should be in the neutral position. What I mean by that is it shouldn't be too flexed, and the chin should not be touching the chest. So in this example, we can see that was done correctly because here is a chin right here, and you can see that this is the chest, upper chest, and there is a gap in between. We can see anechoic amniotic fluid in there, clearly present. And let me draw that so you can see this is the space that I'm talking about. So chin is not touching the chest. So clearly this is a good position. And also keep in mind that the CRL increases at the rate of 1 millimeter per day from 6 to 9.5 weeks. The first trimester is also a very good time to determine if the patient has multiple pregnancy. So it would be much easier, especially if you have a patient coming at third trimester and they've never had an ultrasound done. That's becomes very, very difficult at times, especially if it's more than 2, 3, 4. So here we have a good example. You can see twins over here. And on this other side, we can actually see multiple gestation sacs, and it needs to be determined further down as the pregnancy advances to see how many embryos are present. Of course, we can perform a video. I can show you how we scan. So when you're scanning, you're going to be, especially the transabdominal approach, you're going to scan from cephala to choroid all the way down until the uterus is not seen anymore, and scan side to side and count the number of heads. In this particular example, we see that it is a single pregnancy. Here's the example of twins, and look at how beautiful the images are using the transvaginal approach, because high frequency transducer, you can clearly see two twins are here, and here also, and this, but we only see a single amniotic sac. So this is a monoamniotic twin pregnancy. Here we see a diamniotic twin pregnancy. Next we have early pregnancy failure, which is a very complex topic, but we'll try to simplify it. And there are 4 scenarios in which, you can see that the number 1 being that we have a crown rump length of equal to or more than 7 millimeter with no cardiac activity. So this has a 100% positive predictive value. The second scenario is we have a mean sac diameter. That means we take the 3 measurements and divide by 3 to get the mean sac diameter. And if the MSD is 25 millimeter or more with no visible embryo, as in this example, we have the mean sac diameter of 3.01 centimeter, which is 30.1 millimeter, and no embryo was seen while the sweep was done through both the longitudinal and the transverse plane. So confidently we can declare this as a 100% predictive positive value of a pregnancy failure. The third scenario is we have an absence of the embryo with cardiac activity and equal to more than 14 days after a documented gestational sac was seen without the yolk sac. So this is important. The last scenario, we have absence of an embryo with cardiac activity, and it is equal to more than 11 days, scan showing a gestation sac with the yolk sac. So previously we have done an ultrasound, it shows gestation sac with the yolk sac in there, but now even after 11 days we are still not being able to see that there is embryo with cardiac activity. So these are all ominous signs, bad signs. There in literature you will come across different numbers. Lots of studies have been done, but this is the most conservative. So another thing to remember, if you are in doubt, you definitely want to consider rescanning the patient. So you follow up the patient after 1 to 2 weeks, and also do a serial HCG, beta HCG. Still in doubt, you definitely want to get a consultation with the expert in this field, and we can give you guidance on that, and or send it to radiology for the opinion. So that's very important to be able to diagnose this very correctly, because you don't want to do a D&E procedure on a viable intrauterine pregnancy. Next, to talk about the ectopic pregnancy, very important condition and should be recognized. The most common site of ectopic implantation actually occurs in the tube, the fallopian tube. And out of the fallopian tube region, we see that the ampullary region is the highest incidence of the implantation of the ectopic. There is a slight variation by, if we look at natural conception versus conception after ART, assisted reproductive therapy. But kind of got the idea that normally the pregnancy implantation should occur within the uterine cavity and over here, if it's in the conua, if it's the isthmus or the ampullary region, femoral region, ovary, or the cervix, then obviously it's considered as ectopic. So ectopic pregnancy occurs in about 2% of all pregnancies. It's potentially life-threatening, so therefore should be recognized and taken care of immediately. Possible ectopic in all pregnant patients with vaginal bleeding. So if patient comes with a history of pregnancy and they have vaginal bleeding, you should be considering at least the possibility of ectopic. Beta HCG levels could vary very widely because, if it's just ectopic implantation, the HCG levels may be lower than what would we expect for intrauterine. And the approach, we definitely want to do a transvaginal scan when possible. I've seen patients in which just a transabdominal approach, we're not able to diagnose or recognize the site of implantation of the ectopic. And also keep in mind that the intrauterine pregnancy does not rule out ectopic. So a patient could have both intrauterine as well as an ectopic pregnancy at the same time. Here you can see the uterus and you can see the endometrium here, and clearly there's a ectopic pregnancy here, and you can see this echogenic rim here, and this is the Bagel sign. So the common findings on ultrasound for ectopic are going to be empty uterus, but again, if it was a heterotopic pregnancy, you will see, as in this example, this is a transvaginal scan showing the uterus, and you can see in the uterine cavity there is a yolk sac and there's an embryo. So clearly there is a definite, it's not a pseudo-gestational sac, this is definitely intrauterine pregnancy. And you can also see outside the uterus there is actually a ring here, a ring of fire on the color Doppler, and you can see an ectopic gestation over here. So this is very important to be able to recognize that. And this obviously patient has not had a rupture yet, so you want to recognize it early on. Once it starts bleeding, it's pretty catastrophic bleeding. I've seen patients who bled 2 to 3 liters in the abdominal cavity and they came in shock. And then of course we'll see free fluid, and if you have a patient whose pregnancy tests positive and you see free fluid with no history of trauma or abdominal pain, what else could be? You have to rule out the possibility of an ectopic. The Bagel sign is seen if there's tubal pregnancy, as in this case, and of course embryo would be seen, and this may or may not be seen. You could just be seeing just a yolk sac here. And of course we have, be aware that there could be a situation where you have a bicornuate uterus and the pregnancy could have occurred in one of the horns of the uterus, and that is going to be very, very challenging. So the tip for that is that you will see something really abnormal looking. You'll see 2 uterus, and with the myometrium, and so it's going to be a really strange kind of appearance. So whenever in doubt, definitely get a consult if you're not able to figure out what that is. This is a patient who came with ectopic, and you see lots of free fluid. So this is already ruptured. You can see the bowel loop floating over here. There's the bladder. And of course, this is the cervix, there's the uterus, and this is the endometrium. On both the quadrants, right and upper and left upper quadrant, you see a bunch of fluid present. You can see liver, Morrison's pouch, spine. You can see the right kidney. Morrison's pouch got lots of anechoic fluid. Here we can see the spleen, diaphragm, spine, and you can see the left kidney and perisplenic, and you can see even the pericollic gutters. The bowel loops floating in the fluid. That's all blood. You cannot conclusively say it's blood until you've drained it or done a needle insertion and drained the fluid and tested. But logically speaking, this would be blood because it can be based on the clinical presentation and the urine test being pregnancy positive. Next, we're going to talk about the molar pregnancy. As you know, there are 2 types of molar pregnancy: partial and this is complete. Partial will have a little bit of embryo or fetal content, but the complete would just be a snowstorm kind of appearance with vesicles, and there's no evidence of an embryo. And you have to differentiate between other conditions that may look similar, which would be uterine sarcoma, uterine lymphangioma, and uterine dysgerminoma. But the good news is that on all these conditions, you will have beta HCG and alpha fetoproteins are not elevated, so it's easy to differentiate. Here's an ultrasound image obtained by transvaginal scan. Great case. You can see the uterus is a little bulky and enlarged, and it has multiple cystic structures. I'm going to try to just highlight those right here in the endometrial cavity. But we don't see any evidence of gestational sac or a fetus or yolk sac. And keep in mind that this is a difficult diagnosis, and less than 50% may be diagnosed during the first trimester. And it may appear like intrauterine pregnancy sometimes, but if you look carefully, you notice that really there is no evidence of these structures. If you're not really familiar with those, especially with transvaginal scan, you should be able to get great images, and clearly there is no evidence of any. And the more difficult one would be one in which you actually have a yolk sac, you actually have an embryo developing as well. That would be a partial mole, and that is going to be very, very difficult. But you still, what's going to give away is these grape-like structures that you're seeing, and that would be giving a suspicion that something else is going on over here. And do not confuse with these. These are actually on the side. Let me draw this right here. And so these are venous lakes, and these are not the herediform mole. So just keep that in mind when you're doing this. But this is all this is actually a mole that's developing a molar pregnancy inside the uterine cavity. And also may appear like an empty gestational sac, and sometimes large cysts may be seen in the ovaries as well. So these are the thicker lutein cysts. So if you see large cysts in the ovary, hyperactive ovary, so you should be thinking of perhaps the patient has a herediform mole, or it's a molar pregnancy. Now that we have a deeper understanding of the intrauterine pregnancy developmental process, this is a good time to review the milestones. So we start off with the interdigital sac sign, which is just a little tiny dot or a small collection of fluid that's seen around 4.5 weeks. And then we have the double digital sac sign appear around 5 weeks gestation. That's over here. You can see those two echogenic inner and outer rings. And then we have the yolk sac, which appears at 5.5 weeks, the yolk sac, and it's a very distinct shape. You can clearly see the yolk sac in there. And then we have the fetal pole, which appears, or the embryo, which appears at 6 to 6.5 weeks. And that's what it looks like early on. It's going to be looking like a diamond ring. And then cardiac activity will be demonstrable, especially using transvaginal transducer, when the crown rump length is about 7 millimeter. So let me see if I can play the video. There you go. You can see right here a slight flickering going over here. That is so make sure you don't keep your transducer one level. You kind of angulate side to side, or CPR probe just through the embryo until you detect. You can also zoom in to be able to get a clear view of the cardiac activity. At 7 weeks, we have the amnion that develops, and clearly the yolk sac now separates from the embryo. And there's the yolk sac, and the embryo should be seen very clearly. And the amniotic sac is actually enclosing the embryo, and it fuses with the outer layer as it expands. At around 14 to 16 weeks, it disappears. It doesn't really disappear, it just kind of fuses with the layer over here. So while doing scans, occasionally we may actually encounter some masses. Some of them we classify these into simple, complex, solid, benign and solid malignant. The most common that you will see is a functional cyst, and then it could be a hydrosalpinx, it could be physiological cyst, complex could be like ectopic pregnancy, endometrioma, a hemorrhagic cyst, and benign you have to definitely recognize things like leiomyoma of fibroid uterus. It could be a cystic teratoma, fibromatocomas, and then the solid malignant. Rarely seen, we see sarcoma, primary or metastatic disease. So we have some good examples here. You can see this is a cystic lesion in the ovary, and you can see there it has a classic echogenic mass inside, and sometimes you could see a dense shadowing over here as well. You can see the blood vessel, iliac vessels showing up on the third Doppler. This is a cystic teratoma. And in this example, we see an intrauterine pregnancy, and then it goes, this is the uterus, and you can see a pretty large fibroid. This should be recognized because it could be a problem down the road as the embryo develops. Here are some more examples of adnexal masses that you may accidentally come across while examining the uterus for intrauterine pregnancy. On the left-hand side, we have a classical case of endometriosis, and you see the low-level echoes in here, and in these two cystic lesions. And on the top right, we actually have a classical cystic structure right here. I'm going to draw on it, and you see on color Doppler, you see a ring of fire. You can see this ring here, you know, that is classical. So that means there's increased vascularity over here. And do not confuse this. This is actually an iliac vessel. You can see some high flow state over here. So this is iliac vessel. And so this actually happens to be a corpus luteum cyst. Here is another image at the bottom. In the middle, this is another example of a corpus luteum cyst. And you can, this is what it looks like. See how it is hypoechoic as compared to an ectopic. You see this is ectopic pregnancy, and I'm drawing in the lower extreme right. We see a bagel sign, you know, and we even see a small embryo inside over here. You may see cardiac activity if you zoom in. You may be able to see cardiac activity as well as a small yolk sac present as well. This is ectopic. So this structure over here is the ovary, and inside the ovary we can actually see these immature follicles. So keep in mind that we're not going to confuse this with an adnexal mass. This is a normal structure. This is the ovary. I've just drawn a bunch of those immature follicles in it. So here's some final thoughts. We should be aware of the normal developmental process and be aware of the appearances of different structures as the first trimester pregnancy advances from 4.5 weeks onwards. And also be aware that we want to be consciously making sure that we follow the LR principle, which is stands for as low as reasonably achievable. So we do not want to use power Doppler or color Doppler during the first trimester, because it is first of all not providing us any additional information, and we do not want to insonate the developing embryo with high acoustic power, because that can potentially cause some injury, even though as of today, as I mentioned earlier, there is no documented evidence of that, but it is always a good idea to keep the environment safe for the developing embryo and the organogenesis that's occurring. Always perform transabdominal scans before performing a transvaginal, because the transvaginal, even though it's high resolution, will give us a limited field of view. So you want to make sure you can spend maybe a minute or two, maybe 30 seconds scanning transabdominally. And also especially when you're suspecting ectopic, you want to check out the left and right upper quadrants, and also just a quick sweep in that area, and also paracolic gutters, and a quick sweep through the pelvic region, both longitudinally as well as transversely. Also, the intrauterine pregnancy, if seen, does not rule out the possibility of an ectopic. So that is something that you keep in mind, that if you see an intrauterine pregnancy, there still could be an ectopic pregnancy, or something called as heterotopic. So we have both intrauterine as well as extrauterine pregnancy. Do not be in a rush to conclude early pregnancy failure unless you have those 4 scenarios that I mentioned earlier. But even then, you would still, if you have in doubt, you want to consider a repeat scan after 1 to 2 weeks. The reason for that is that we do not want to do a D&E procedure on a viable pregnancy. The crown rump length is the most accurate measurement of gestational age that you can obtain during pregnancy. It is so important that sometimes a patient, the fetus grows and it is not growing well, and there is intrauterine growth retardation, or the limbs are short, or something could go wrong. And at the time of the towards the end of the 3rd trimester, you want to decide about delivering or performing a C-section. And that time, if the gestation age is not coming correctly or corresponding as far as the fetal parameters are going, then you will want to actually consider looking at the old report that you obtained earlier in the 1st trimester. And so based upon that gestational age that you obtain using, or someone else obtained using the crown rump length, you can actually calculate the true gestational age from that point. On the right hand side, I actually have an image which was obtained using a 3D transvaginal transducer, and you can see here, you see something really interesting. You see an intrauterine contraceptive device, and also you see intrauterine pregnancy. I like this image because not only showing that you can be shocked at times when you're scanning. So if you see something like this, obviously this is a 3D transducer, but if you had 2D or a regular transvaginal transducer, you could be seeing just an echogenic dot representing the intrauterine contraceptive device. If you had done a transabdominal scan, you would have seen that the patient does have also an intrauterine contraceptive device inside the uterine cavity. And here you can see the double decimal sign, and as well you can see that it is eccentric in location, and that's why it's got a lot more information. So it's that's why I want to share with you all that. You can see that there also is a tiny embryo in there, and if you probably zoomed in, you could have seen the cardiac activity as well. So the lesson learned is be aware of findings and morphological changes that occur during the 1st trimester, and if you see something, keep an open mind and say, oh, I see something echogenic in there, and then you definitely kind of look at that and be saying, oh, this is actually an intrauterine contraceptive device that is coexistent with intrauterine pregnancy. I would like to thank everybody for participating in this webinar. Now we will have a Q&A session. You can submit your questions, and I'll be happy to answer.